Hello. Okay, let's get started. We have several announcements and two speakers today. It's my pleasure to introduce today our first speaker, Christina Wood. Christina, she earned her medical degree from the University of Colorado and then did her anesthesia residency training within our department and joined our faculty in 2011. And 2012, she already became the medical director of obstetric anesthesiology for the Colorado Fetal Care Center. And because of that expertise and knowledge, she also now represents on a national level and is a member of the Patient Safety Committee for the Society of Obstetric Anesthesia and Perinatology, also called SOAP. She's also a dedicated, highly awarded teacher and researcher, and she has over 20 publications in peer-reviewed journals and is highly interested in quality improvement and patient care. And then our second speaker is, I would say Julie, but it's Jennifer Hong, and Jennifer also earned her medical degree from the University of Colorado and also did her residency training within our department. And she's currently a senior instructor and an obstetric anesthesia fellow within our department, and she received several awards during her residency. One, for example, as the Outstanding Resident of the Year, but also the award for the best QI project and presentation. And as such, she's also highly interested in QI projects. And today they both will present some very interesting cases about complications regarding epidural anesthesia in the obstetric anesthesia setting. Thank you so much. Thanks.
Thank you. Thank you guys for showing up so early. I just want to say we'd like to make this interactive, as you've seen before. So can everybody see what you need to text and the numbers here? Or who can't? Okay, so if you want to get yourselves logged in, we'll have some questions for you to participate in. All right, so our talk today will be on 3 different cases in OB anesthesia, and we cleverly titled this When Epidural Catheters Go Rogue, because it feels that way sometimes after you've placed a catheter and you're not really sure what's happening. We have nothing to financially disclose. And so when you place a labor epidural, most of ours are going to be in the lumbar region. You have beautiful loss of resistance. The catheter threads easily. So absolutely, of course, it is in the epidural space. Where else would it possibly be? Unfortunately, as we find up there on occasion, we don't know. But we're hoping we can give you some tools and some information today to really delineate in some of those tough situations what is the best course of action for those labor epidurals. The first case is going to be talking about local anesthetic toxicity and how that specifically relates to pregnancy. So I'm going to talk about one case here. I actually wasn't a provider on this case, but I've talked pretty extensively with the individuals who were. This is a G2P0 parturient, so this would be her very first vaginal delivery. She was being induced prematurely at 33 weeks because she had developed preeclampsia with severe features based on blood pressure and headaches. About 3 in the morning, we got called to place a labor epidural, and it was a difficult placement. The first attempt at L3, L4, they were unable to access the space. Tried again at another level, were able to access what they thought was the epidural space, but we do combined spinal epidurals most of the time on labor and delivery. So when passing that spinal needle, it was not returning any CSF, so there was a little concern of being off midline. They repositioned and tried a couple more times, then finally went paramedian, had a great loss of resistance, actually was able to get CSF return and thread the catheter easily. So this catheter that was placed did well for about 12 hours, and then they were called for some lower quadrant, just unilateral pain. Patient was bolused with 8% bupivacaine. This is a pretty standard dose that we use for bolusing our labor epidurals. Did well for a few hours, had some recurrent pain again just on one side, bolused again. About 9 o'clock that night, now her entire one side was not getting any pain relief, so it was just a unilateral block. So they decided to replace it, and this time it actually was an easy placement, loss of resistance at 5. The catheter was initially threaded fairly deep and found to be intravascular at 20 centimeters. It was then pulled back to 10, negative aspiration. The team decided to go ahead and do a test dose. We don't routinely do test dose on OB for a variety of reasons we'll talk about, but they decided to do a test dose. Her heart rate increased about 15 beats, which was a little difficult to tell if it was related to the epinephrine or related to a contraction pain. But she also had some mild unilateral ringing in her ears. The aspiration on the catheter was still negative. The team decided to proceed with this. Did well for a number of hours. About 1:30 in the morning, got called for some increased pain again. Bolused with another test dose, actually a little more than a test dose, 5 cc's of 2% Lido with epi. Again, increase in heart rate, concern that this may have been related to contraction pain. No CNS symptoms, no ringing in the ears or anything like that. The patient says, yeah, maybe I got some relief from that. And they decided to continue with the catheter. About 45 minutes later, same situation, increased pain, patient's not comfortable, bolused with a cocktail of some 3% chlorprocaine and a little 0.25% bupivacaine. Again, saw some tachycardia with this, no CNS symptoms, and the patient said, yeah, I think I feel a little bit better. So about an hour later, it was decided that she just was not progressing in labor. She now had an infection in her uterus, and with the whole kind of clinical picture, the obstetric team had decided, you know, we're going to head back for a cesarean delivery. In the labor room, the chlorprocaine was bolused 15 cc's, 3%. This is a standard bolus we would give for a C-section, but almost immediately the patient lost consciousness, began to have seizure activity, tongue protruding out of the mouth, the heart rate shot up, and this lasted for about a minute or two, and then the patient regained consciousness. The fetus was actually looking okay during this time. Now the team appropriately called for interlipid. They had an epidural cart in the room that always has airway equipment, so they were getting the airway equipment in case they needed to intubate, but mom recovered very quickly. And fortunately, chlorprocaine is metabolized intravascularly very, very quickly. Half-life is a matter of minutes. And as you'll see in a minute, this was not a full toxic dose necessarily. They let the patient recover while moving to the operating room, and decided to aspirate the epidural catheter again, still negative aspiration, removed the epidural, did a single shot spinal on an uneventful cesarean delivery. Mom did well, baby did well, fortunately. But kind of our philosophy in general is when you're encountering any of these epidurals, you're not sure where it's at, things aren't making sense, just go ahead and replace it. It's not worth getting into a situation where you certainly could have seen significant local anesthetic toxicity, some cardiovascular collapse, especially with our longer acting local anesthetics. And in obstetrics, this is something we'll see we're at risk for pretty routinely. The epidural space is very vascular, the epidural veins are very engorged in pregnancy, so it's something we need to be well aware of. And I'm just curious, I'd like everybody who has their phones out to go ahead and text A, B, C, or D what you think the toxic dose of chlorprocaine is. And then do I just scroll past it? Okay, all right, so it looks like most people are saying 15 milligrams here. You guys are close. It's actually reported at 12. Interestingly, our case, she got 7 milligrams per kilo and still had significant toxicity symptoms, which we definitely can see in pregnancy. Pregnant women are at higher or more sensitive to local anesthetics, so we have to be very mindful of our doses. And as with all local anesthetics, it's very important, something you're administering, especially administering quickly as we tend to do chlorprocaine, that you're well aware of what those toxic doses are and how you're going to resuscitate mom. So in general, what you're going to tend to see is auditory symptoms, maybe some ringing in the ears, maybe a metallic taste in the mouth, maybe some agitation. These are what they kind of consider mild toxicity symptoms that will then progress on to seizures, then your CNS depression, cardiovascular collapse, and death if left untreated. Now, I say this is typical because about 60% of cases present this way, but certainly in the literature, a whole nother 40% can present just CNS or a combination. Rarely is it just cardiac, but we can see that as well. So what do we do to try to prevent these? Well, in general, patients that have underlying pathologies such as renal disease, cardiac disease, liver disease, we want to err on the side of giving a little less local anesthetic. Incremental dosing, so not giving big doses at once. Aspiration, and we're going to talk about that because this was certainly the team had aspirated and had done their due diligence to check this catheter. Ultrasound guidance for peripheral nerve blocks has been shown beneficial. And then test dosing. As I said, on obstetrics, we don't routinely test dose. One, false positives can certainly happen when patients are having labor contractions and pain. Our preeclamptics, where blood pressures may be significantly elevated, we don't want to increase those anymore, as well as fetal perfusion. That being said, it's not contraindicated to test dose a labor epidural. It's just not, it's something we want to really do our due diligence to think about. We don't necessarily do it on everybody. So the reason pregnant patients are more sensitive to local anesthetics has a lot to do with protein binding and increase of their free fraction of local anesthetics. So this is why you can certainly see toxic doses and symptoms at a lot lower dosing than you would in your non-pregnant counterparts. There are also some reports saying they're probably more sensitive from an arrhythmia standpoint. We blame everything on progesterone in pregnancy, probably contributes to some of that myocardial sensitivity. All right, so next question, if you guys want to go ahead and type in some answers. What do you think the incidence of intravascular catheters in obstetrics are? How often do you think we would see these? If you're saying 25%, sometimes it definitely feels that way. All right, another few seconds. Okay, you guys are pretty good. So majority said 5%, and actually with our combined spinal epidurals upon obstetrics, that's what we see is about 5% intravascular catheters. That's what the literature also publishes as well. Epidural catheters that may be a bit more off midline are a little higher rate of intravascular incidence, about 7%. And there are plenty of cases, although it's only about 0.25% of catheters that are not intravascular that migrate after that. Aspiration, why I said that's so important for us, is majority of the time it's going to be a great way to assess an intravascular catheter. The epidural veins are large and engorged, and typically with multi-orifice catheters, you're able to get good aspiration if you are intravascular. There's been a few studies, although older studies, but looking at thousands and thousands of obstetric epidurals showing that that false negative rate is extremely low. So interesting in our case that it fell in that 0 to 0.4% of negative aspiration. In general, last has been published of incidence of about 1 in 10,000 in epidurals. Again, in pregnancy, those engorged epidural veins certainly put you at higher risk, the systemic absorption. And I just want to mention too, as far as local anesthetic toxicity, tap blocks are something that we do occasionally on OB, especially for our women that get C-sections and can't get neuraxial anesthesia for a variety of reasons. I don't know, and I couldn't find what the incidence of last is in tap blocks, certainly in obstetrics, but there's been several studies that have looked at pregnant patients and drawn serum local anesthetic levels and found that these local anesthetic levels will take a while to peak. It can be up to 30 minutes after you've placed that tap block. And in these patients, there actually were some mild toxicity symptoms from that. So it's not a totally benign procedure and something you definitely need to be aware of and prepared for. The good news is when looking at some other large published studies coming out of the UK, there's very few deaths from LAST. So one in from their 2003-2005 report, and no deaths on their follow-up report. There was one in a French inquiry as well that was a death from LAST, but it was also due to no intralipid treatment. When I did a pretty good literature search, looking back over the 15 years or so, there's certainly a handful of cases that have been reported. So for labor epidurals or neuraxial on OB, there was a last case of one labor epidural that was bolused and was intravascular. An epidural that had been placed for a C-section that was bolused also resulted in LAST, and a labor epidural that was just under a continuous infusion for about 50 minutes. The patient started developing symptoms of LAST, and this was also an intravascular catheter. TAP blocks, handful of those as well. The first case was a woman that actually had some liver dysfunction. So again, her protein binding was even lower, and the doses were not adjusted in that situation. Another case was an error in dosing. The surgeon actually placed a TAP block on the surgical field, and there was not real good communication. The anesthesia team came and then subsequently placed a TAP block, so that patient developed toxicity. The other two were very uncomplicated, very straightforward cesarean sections that got TAP blocks. So it's definitely something that we can see. This SCORE project, you'll hear Jenny talk about this in her cases too, but this was a very, very large study published in 2014 looking at complications in obstetric anesthesia, and it looked at over 250,000 OB anesthetics from many different institutions. Interestingly, with all of those anesthetics, there was only, fortunately, one case of local anesthetic toxicity, but it was due to a TAP block, and it did result in cardiac arrest. There were only 2 cardiac arrest cases related to anesthesia in this study, and one of those was due to local anesthetic toxicity. So just a reminder, how do we treat it? You're going to want to do your basic ACLS in your pregnant patients just like you would your non-pregnant patients. You know, that acidosis is something that really can make things a whole lot worse, so ventilation and perfusion is key. Benzos are first line. Propofol is an option. You just have to be mindful, as we know its hemodynamic profile. And then muscle relaxants for the patients that continue to seize and maybe impeding some of that resuscitation with those muscle contractions is another option too. So these doses got changed a few years ago, and I'm just wondering what everybody thinks as far as appropriate dosing for epinephrine in LAST in pregnancy. Nobody's going for the full milligram, huh? All right, I'm going to stop it there. You guys, 74% of you are absolutely right. They changed it to much lower doses. It's the same thing in pregnancy. So lipid is going to be your first line, but then if you're given epinephrine, make sure you're going lower doses. It is arrhythmogenic. They also took vasopressin off of the resuscitation, found some poorer outcomes. And obviously you want to avoid more local anesthetic, beta blockers, those kinds of things. None of this is any different in pregnancy. So interlipid's going to be your best. We have this on the OB floors. We have this in all of our block carts for our pain service as well. You know, different theories as to exactly why this works, but the idea is you're redistributing, taking it away, minimizing its toxicity with the lipid infusion. The bolus in pregnancy is no different than non-pregnant. It's still the 1.5 cc's per kilo followed by an infusion. Make sure you're monitoring these patients. You know, there are potential complications, but certainly survival is key. We're willing to run the risk of, you know, some pancreatitis and lung injury for survival. So I'm curious, though, what everybody would do. So lipid emulsion does cross the placenta. So should we be doing a C-section, get that baby delivered before we're administering this to mom? If you think that that is true, A, false, B. Strong work. So absolutely. Just go ahead and give it. There's no trials I can show you that they've randomized pregnant patients with LAST to getting or not getting interlipid. But there are plenty of case reports showing absolutely zero neonatal complications from giving interlipid in moms that have developed LAST. The closest thing that we can do any research on is TPN, which has a very similar lipid concentration, but this is also something that's run over time, not single doses, shorter infusion periods. But even in those cases, moms on TPN have showed very little complications regarding that. There was one in a 22 case series, one IUFD, that it wasn't really clear was even related to the TPN. Neonates get TPN as well. There's certainly been fat emboli reported, pulmonary fat emboli reported, but again, unclear association. So at the end of the day, mom survives, baby survives. That's a good thing. So absolutely, just like anybody else, you want to give it as fast as you can. And just one last reminder too, if you are in cardiovascular collapse and you're doing full resuscitation, the guidelines in pregnancy for perimortem delivery of that fetus is if you haven't gotten return of spontaneous circulation within 4 minutes, it's indicated to do a cesarean delivery, not because it's actually for fetal survival, it's for maternal survival. That fetus is taking up very important nutrients for mom. And so if you can't get that return of circulation, it's recommended to get that baby out. All right. Dr. Hong is going to come talk to you about 2 other cases, and then hopefully we'll have some time for a few questions at the end.
All right, thanks, Christina. So the second case here, as you can tell, is going to be about high neuraxial anesthetics. Can you guys hear me? Okay. So through the discussion of this case, as well as some of the literature, we're going to familiarize ourselves again to the signs and symptoms of high neuraxial anesthetics, as well as understanding what places a patient at risk for one. So without further ado, we'll talk about the patient. This is a G1, so prime MIP at 39 weeks gestation, who has a history of migraines, presenting for an external cephalic version for breech presentations. So the fetus was malpositioned and not set for vaginal delivery, so has to have a turn by the obstetricians. The patient was admitted to labor and delivery where she was confirmed to be having a fetus in the breech position. She was given pre-medications and was currently in the PACU in labor and delivery. So anesthesia is involved in about half of these cases, assisting the obstetricians and allowing for the patient to be more tolerant for the turn itself. So in this situation, we chose to do a CSE, placing an intrathecal dose of bupivacaine 2.5 milligrams or 1 ml of 0.25% bupivacaine and fentanyl 15 mics. The obstetricians were brought into the PACU where terbutaline was given for uterine relaxation, and then they attempted the external cephalic version. Unfortunately, it was not successful. Baby ended up having a little distress, bradycardia for about 4 minutes, and then recovered fully. In the setting of her being 39 weeks pregnant and the fact that the baby was appropriately recovered, there was a joint decision to move forward for a cesarean section. However, both of them were veterinarians and the husband was currently doing a surgery, so we delayed the case for a couple hours until he was able to arrive to L&D. Within the next hour or so, we decided to continue to use the epidural in order for us to use it for the C-section. We tested her dermatomes, which was around T9, 10. She still continued to have a motor block, which is anticipated with even that low dose of bupivacaine. We aspirated a catheter, it was negative for CSF, and decided to do a low dose epidural infusion, around 2 to 3 cc's of our cocktail up on L&D. However, subsequently, we started to see intermittent hypotension down to the 70s, and then baby was also showing signs of bradycardia, however, having fast recovery within 60 seconds or so. So we continued to monitor mom, continued to monitor baby, until finally about the 2-hour mark when the baby ended up having a pretty significant bradycardic event with a slower recovery, and the obstetricians were more or less concerned about abruption. So we decided to move forward. The anesthesia team ended up testing dermatomes again in motor function and was surprisingly alarmed when it was a higher dermatomal distribution as well as more motor block than we had anticipated with that infusion. However, the catheter again aspirated negative and was given a lower dose of chlorprocaine due to the fact that the clinical signs seemed a little alarming. So we only gave 5 mLs of 3% 2-chlorprocaine. We were transferring over to the OR when finally on monitors, we noticed that she was hypotensive into the 60s. She had some motor strength in her arms, but were getting progressively more tingly. She said that she had a harder time breathing as well as a harder time vocalizing what she needed. So as we were able to mobilize up on L&D, we were able to support her blood pressures appropriately with high doses of phenylephrine. And after a certain point, she had no strength in her arms. It was decided with the patient nodding that we would move forward towards a general anesthetic, and we proceeded forward with intubation. However, again, encountered a very difficult airway. A grade 3 view, we needed an Eshman and the video laryngoscope. No complications there, and we were able to keep her supported under general anesthesia. The baby was delivered with no complications, went over to the NICU for temporary resuscitation. However, at this point, after the baby was delivered, we had positive CSF, and so declared it to be an intrathecal catheter as we were preparing to give her some Durmor for long-term pain relief. Other things just to note is that we went ahead and started our protocol for post-dural puncture headaches, giving cosatropin as well as keeping the catheter in for over 24 hours. And despite that, she had a post-dural puncture headache, for which we had to do a blood patch ×2. So just to review the signs and symptoms of a high spinal. So as would be expected for any intrathecal dosing, we would have a sympathectomy as well as a sensory motor block. However, as we continue to have a spinal that is ascending further than we anticipate, you'd start seeing bradycardia, hypotension, and then the patient starts to complain of shortness of breath, difficulty speaking, difficulty swallowing. And of course, as it progresses further, and if you were to come up on L&D and you find a patient unresponsive, high spinal should also be on your differential. Like Christina mentioned, we're referring back to the SCORE project from 2014. Again, over 250,000 cases coming from multiple institutions around the U.S. where we have the best information available to us of serious complications in obstetric anesthesia. Here in purple, you can see that the rates of high neuraxial block is 1 in 4,300. So not incredibly rare, but rare. And total of 58 were reported in that study. They were able to further delineate what the associated techniques are related to having a high spinal, as well as what are the risk factors. As you can see here, the unrecognized spinal catheter, which accounts for about 24% of those cases, is similar to what we had encountered. And initially, we thought it was an epidural catheter up until this point. So if you were to add to what was previously documented, about 60% of epidural catheters, more or less, have a likelihood of having a high spinal. So keep that in mind, and it's not just a spinal dose itself. And then the other thing I wanted to highlight is regarding risk factors. So if you look on the second line, there's spinal technique after a failed epidural catheter. So for individuals where you end up having an epidural catheter in labor, where they're one-sided, as we had seen in our first case, or you're having a patchy block, oftentimes there's a choice to remove the epidural catheter and give an intrathecal dose. It's in the setting of giving a full anesthetic dose for C-section that you have this high risk for a high spinal. So in our institution, we give about 1.5 milliliters of hyperbaric bupivacaine. The reason why that technique is of concern is clearly kind of delineated in this myelogram that was performed in 1997, excuse me. This is in a non-obstetric patient. And what this study had done is inject contrast into the intrathecal space at L4, L5, and gave various doses of epidural saline to see how much of a spread you would actually have in the intrathecal space. So on the left is an individual who got a certain amount of contrast and saw that there was only one level of dermatomal distribution, cephalad and caudad. However, as you increase the amount of epidural saline bolus prior to that intrathecal dose, you see that ascension of your contrast itself. And in the setting of a parturient who has a gravid uterus compressing into the lumbar space also, you would imagine that that would spread even further. So this is the reason why high spinals are so likely in the setting of someone trying to replace an epidural catheter with single dose. So in terms of management of high spinal, of course, the first and foremost thing is early recognition. And then understanding where your airway and emergency equipment is. I think oftentimes individuals who are up on L&D have a familiarity with where the carts are and what's in the carts, but those who are covering overnight or on the weekends should be familiar with where you can find all the airway equipment. So of course, early intervention, supporting them with their breathing as well as intubating as promptly as possible is very important, as well as knowing where all of your medications are to support blood pressures. I want to call attention to one article that was published in 2018, and we'll provide references to so you can see some of the data yourself. So this was a group from Massachusetts, specifically with the Harvard Medical School and their affiliated institutions, looked at malpractice claims related to obstetric anesthesia from 2005 to 2015. There were 2,900 approximately closed claims data related to anesthesia, and of those were only 106 related to obstetric anesthesia. Majority of the cases were related to nerve injury. However, of those cases, less than 0.25% ended up having cases settled. There are 15% of those that ended up having some pretty significant mortality, morbidity, 16 cases total, and of those, 62% ended up having a settlement. 5 of those 16 cases were due to high spinals, and 1 was due to the fact that no airway equipment was readily available. And of those, the median payment was close to $1 million. So one thing I just wanted to highlight, and I think there's a lot of understanding that airway management in obstetrics is of a concern. However, in the setting of video laryngoscopes and LMAs and understanding the difficult airway algorithm, oftentimes it's not due to the airway that we end up seeing any suits or claims. It's typically due to the lack of awareness or lack of recognition and early intervention. And then I only wanted to bring this up in terms of subdural epidurals because I think there was a suspicion that our catheter initially was in the subdural space. And this is a study from 1988 showing that there were 2 major criteria and 3 minor criteria that places a patient at, or at least an epidural catheter in the subdural space. So negative aspiration, as we had seen in this patient, an unexpected high sensory block, which was anticipated prior to going to the OR, and then all these 3 minor criteria. Christina mentioned that the chances or the incidences of a migrated catheter is about 0.25%. It's incredibly rare. However, using your clinical gestalt in assessing a catheter, it's important to know that if something doesn't seem quite right, maybe pause and consider replacing or doing a different technique to help support that patient. All right, now we're going to move on to our last case. So trouble in labor land. In this section, we're going to be talking about troubleshooting the imperfect labor epidural and recognizing the risk factors of a failed epidural. And this is where I need your participation. So not testing your knowledge, but just needing your participation altogether. We're going to do a choose your own adventure. So imagine that you're on the labor and delivery floor and you're encountering a laboring patient. G2P1, she's 38 weeks, 3 days, and is in active labor requesting an epidural immediately. So you have a choice. Do you grab a coffee or do you place a CSE? Okay, great. You guys are great. I'm so glad to hear that you guys want to place a CSC for this poor lady. So great, you place the CSC. It is the perfect epidural. By the time you call your attending, you've already placed it. Great loss of resistance. Everything suggests that it is a perfect epidural. Your loss of resistance at 5.5, you thread the catheter to level the skin at 11 centimeters, and you're ready for your next CSC. However, 1 hour later, you get a call from the nurse. The patient says, I feel the pain returning on my left side. Do you bolus the epidural with 10 mLs of 1/8% bupivacaine, or do you decide to pull back on the epidural catheter 1 centimeter? So what do you choose? I think you guys have been listening. I think in standard practice, if you were to encounter this patient, we would consider bolusing as a trial. However, we're going to go ahead and pull back the catheter. So you are, excuse me. So you adjust the epidural catheter by 1 centimeter, and then you bolus the catheter with 10 mLs with 8%. Patient says, I feel so much better. I don't feel anything. So just wanted to shed light that there was recent meta-analysis study showing that obstetric anesthesiologists are more likely to manipulate an epidural catheter than a generalist. So let's change that paradigm. Of the reported epidural catheters, 85% of them that were reported to be failed, they were able to convert successfully to a surgical anesthetic by withdrawing the catheter by 1 centimeter. Of those individuals who were troubleshooting the epidural catheter, 58% of them were obstetric anesthesiologists and 6% were generalists. So just remember, if you do this technique, go ahead and bolus the epidural, of course, and then supplement the block with potentially fentanyl. I wanted to go back and just let you know a little bit about the bolused epidural. So if you are taking over a shift and your colleagues say, hey, I bolused this catheter a couple of times, it should put an alarm to you and saying, hey, maybe this catheter is not going to be as successful as I would want it. So increased number of epidural boluses is associated with higher epidural conversion failure rates. So they're less likely to be reliable for a surgical epidural. So one study showed that one planned bolus increased your odds by 2.37. Others said that it's almost threefold. And then Orbach and Zinger says that it is the best predictor of a failed epidural. So just put that in the back pocket if for some reason you're up on L&D and you notice that someone has had multiple epidural boluses, that you may need to have a backup plan readily available. All right. Now, you get a call from your OB folks and they say, hey, we need to go back for an urgent section. Do you trust your epidural catheter for a cesarean section? Okay. Seems like we're almost half and half, but we'll start with I have my doubts. So for individuals who have doubts of their epidural catheter, the options are typically to remove the epidural catheter, place a spinal, or go for a general anesthetic. So as was mentioned with the SCORE project in 2014, make sure that you're very conservative because you just don't know what dose of spinal you need to give to prevent a high spinal itself. Like it was mentioned, about 20% of the high spinals that were reported were due to individuals who had failed epidural catheters and placed a full dose of intrathecal bupivacaine. In our practice, and if you were to poll some of the obstetric anesthesiologists, some of us consider doing a low-dose anesthetic, so doing 1 cc of hyperbaric and then threading in a catheter so that you can actually extend the block. And then the other thing I wanted to mention is if you decide to move forward with a very well-working epidural, 25% of epidural conversion failures are due to emergent cases, and it has to do with the fact that you just don't have enough time for that epidural to set up appropriately. The odds ratio shown in Bauer et al. Was in the order of 40.4. So if you get a call from someone saying we have an urgent cesarean section, make sure you're clarifying if it's urgent versus emergent so that you have appropriate amount of time to continue using that neuraxial. Other things that we wanted to make sure and highlight to you is that general anesthetics, although we tend to shy away from them, are significantly faster in terms of allowing patient to be comfortable and allow the obstetrician to deliver the baby sooner. In Beckman et al., it says that it's 8 minutes faster compared to setting up a labor epidural. One thing to mention in that study is that there was an increase in fetal morbidity shown related to those who had general anesthetics. However, it was confounded in the setting that the baby may have already had some underlying pathology that was clouding that outcome. So what does it mean to have a failed epidural? Majority define it as a conversion to general anesthesia, or others say that it's due to using another form of anesthetic, so using ketamine, narcotics in the IV. Biggest thing for us to know is that failure rates are anywhere in the order of probably 10 to 21%. In this one study of 19,000 studies reviewed in a retrospective analysis, it was 12%. 46% of those epidural catheters that were considered initially failed were functional after a simple manipulation, and about 7% need to be replaced. Arendt et al. Ended up also doing another study showing that with active management, so bolusing, walking into the room, talking to the patient, and assessing accordingly how the epidural is working in labor, has nearly 100% efficacy. So be very active and don't let the labor epidural kind of fly by without getting a good assessment of the patient and understanding how it's working for them. Other things that one of the meta-analysis showed is that height, weight, and the duration of epidural that is being used does not affect necessarily a failed epidural. The asterisk and the weight is noted because oftentimes there's not many studies with people with high BMIs, and also there was only one study suggesting the correlation. So we still need some more information. I don't necessarily think we can rule out that BMI is necessarily a reason for a failed catheter. We wanted to also show what the University of Colorado Hospital data shows in terms of our conversion rates. This is from 2016, and we still have some more data moving forward for 2017 and 18. In terms of how we're performing on LND, we are close to the standard and meeting it. So as our unplanned general anesthetics in the order of 5.7%, so 1 in 20 or so. And then lastly, I just wanted to call to your attention, again, another medical legal consideration. This is an article that was published last year in 2018, looking at 21 years of litigation in the UK regarding pain during cesarean sections. As you may or may not be aware, in the past couple of years, there have been case reports of individuals who have reported feeling everything during a cesarean section. In this review, looking at the actual court proceedings, 42% of the cases proceeded despite an inadequate block. 33% of the anesthetists that were involved in those cases refused to accept that the block was inadequate and refused to do a general anesthetic. If you get a chance to read the articles, there are actual quotes from patients and how they perceived their delivery, incredibly painful to read at times, but really resonates that, pain is a perception, and whatever the person is experiencing it says it is. And just believe the patient who complains of pain and have other tools available. And then in summary, for this section, if questioning the location of the epidural catheter, please make sure to consider replacing it. High neuraxial blocks are likely to occur with single shots after an epidural has been running for a while. Conversion or failed labor epidurals are typically in the setting of multiple boluses or in emergent cases, and then make sure you believe the patient who has pain. So we'd be happy to chat about any cases that you guys have questions about, or any other questions that you have of the cases that were discussed today. Yes?
You mentioned a lot of
So the question was, is there a difference in the type of epidural catheter we use and the incidence of complications like intravascular migration or placement? And there's firmer catheters we tend to use on OB. There's also spring-loaded catheters that are a bit softer. Not that I saw that anybody's studied that. I know plenty of people that place some of these feel that the spring-loaded are less likely to poke through those veins, but not that anybody's studied that I saw. Well, so it depends on a lot of different factors. If the patient is multiparous, how big the baby is, position of the placenta, experience of the obstetric provider. So it's really hard to say without kind of teasing out that patient population. But definitely helps if we get involved with their success rate. Absolutely does. So the old studies, when you looked at single orifice catheters, very different than looking at multi-orifice catheters and aspiration. So definitely, and what we use is multi-orifice catheters and should be fairly sensitive for that aspiration. So it's interesting in this case, over many aspirations, that there was no heme aspirated, and yet it was clearly intravascular. And you're saying there's a lot more that were intravascular that were negative. And how are you confirming they were intravascular? Positive test dose? Yeah. Like I showed the studies, over 12,000 patients when they looked at that, found that the false negative was very, very, very low. But obviously it can happen. Yeah. So that's why kind of when in doubt, test dose. And I think looking at that case, hindsight, just getting rid of that catheter, even with a negative aspiration. Okay, thank you guys. You don't have to head out yet. Patrick's going to do a quick EPIC update.
Well, it's not so much EPIC per se as this work, as our quality reporting tool. So, as many of you know, we use a homegrown tool to report adverse events in the system, and we both record cases when something happened and nothing happened. Well, unfortunately, that system that we've been using is designed and housed in the anesthesia department. And with some of the changes in security protocols for this sort of information, as you can imagine, highly confidential information, it's been deemed that our system really isn't secure enough to house that information. We took a look and saw if we could beef it up or figure if we could continue to use it, and we weren't able to do that. So what we did instead is modified the hospital system to allow you to enter adverse event reports. And go ahead and just pull up a random patient. And what I want to show you is how to use that. Now, the key difference here is, at least for a period of time, we're not going to be able to enter cases of when nothing happened. So click RL Solutions. So RL is the new tab to be able to do this. You can see that button there. And go ahead and log in. You have to select your domain. So this is the key here, is to pick the right domain, which is a pain. You would think that would come through automatically, but it doesn't. And then when you're in this system, you can see at the top of the screen, there's an icon that says Anesthesia. If you click that, and the reason you want to click that is because we worked at the hospital to cut the number of required fields way down to be able to use this thing. And you can see up here, if we start at the top, it has specific event type, and then you can kind of scroll through the options. So pick a random place if you would, maybe OB. Stick with the theme, right? And then event severity is the next one. This is a very standard way of reporting event severity and how we think of it in terms of patient safety literature and how we classify events. The good news is if you hover over one of those, it'll give you a definition. I sent out an email with the full description of all of these, and also keep in mind, this is your best guess at the time you put the report in. We can change this behind the scenes if further information shows us that, say, temporary harm proceeded to permanent harm, for instance. And then the other things we need to do is just write a brief description of what happened. That's pretty current. The event date below. You can click today at the bottom to make it easier. And then the time, just put in the approximate time in military time. And then the site, probably be Metro Denver for most of us, or all of us. Location, then it'll automatically populate a reduced list of hospitals on there. And then department can be anesthesia, which is on the list. And if you see over now on the right side, it says 13 out of 14 mandatory fields completed. That's the green over there. And if you scroll down, what's interesting is you'll notice that under person affected details, it's populated the MRN, the name, all of that information for us, which is huge. So if you do this through Epic, it'll automatically pull all that information in. You won't have to do any of that. So that's a little bit of a benefit too. So as you can see, it's reasonably quick. We got through this form in about a minute, and then just would take another minute or two to enter the case description and go through it. We're going to work more in the future to find a secure way to kind of get the technology back we had before. But at the present time, this is what we have that meets the safety and security requirements of this sort of information. I've also been asked by Gabby, she's on the phone, to let you know that if you have an IT or an Epic issue or something other that is very time dependent, that this is not the system to use for that sort of thing, go ahead and call the phone numbers that you have, because it might take a day or two for somebody to even look at what's in the system, especially with Gabby headed out on maternity leave. So that'll rely on some of us to go in and look at the data. So please continue to use those phone numbers for that purpose. So I'm not sure that this, well, I know this doesn't represent the most ideal plan forward, but it's what we were able to do on a short time frame to be able to continue to have a way for us to be able to report adverse events in a much easier fashion than what the rest of the hospital does with this system. Any questions?
So, this is going to replace the quality button, so we
Yep.
no longer use that. And then the second question is, when you have no issues with the case, are you just not filling anything out?
So 2 questions. First, does this replace the quality button? The answer is yes. We're going to turn that off tomorrow night. Second question is, if nothing happened, if the case went great, do you have to do anything? At least for a period of time, the answer is no. We don't have the hospital decline to receive 40 or 50,000 reports a year of nothing happened in their incident reporting system. So until we can find a way around that, we won't be recording quality information for every case. We believe that's a step back, but that's where we are at the present time.
I have a question. So it looks as though that I'm logged in as the individual writing this report.
Right.
So if I'm working with an APP or a resident, are we accessing the same report, or is it only filed to one individual?
It's only filed to one individual.
So there has to be clear communication between the providers in the room.
Yep, somebody should. Now, the worst case, both of you put a report in. That's not a big deal. We'll just drop one on the review stage, and sometimes that can actually be helpful to see different people's perspective on the same event. As far as whether you report or not, if you think you should report, you should probably report. If it comes to mind, put it in. There's certain protections that we can offer by putting the information in the system and reporting it. Allows us to also come up with solutions to things, because if you don't report it, we don't typically know about it. So allows us to intervene. Another example of why it's important to report is, let's say we want resources like new anesthesia drug carts or label printers or things of that nature. The more reports you put in, those are going directly to the hospital, and we can show those as evidence of need for capital expenditure. So if we get 20 or 30 reports showing that mislabeled syringes are a problem, that provides the business case for us to be able to purchase equipment. So really a lot of benefits to putting these in for how we operate behind the scenes. Any other questions? Have a wonderful day.